Question 1. You arrive on the scene of a single vehicle collision where a car has struck a tree. The driver is unconscious, slumped over the steering wheel, and has obvious facial trauma. After ensuring scene safety and donning appropriate PPE, what is your immediate priority regarding the patient's airway? A. Insert an oropharyngeal airway, OPA. B. Perform a head tilt, chin lift maneuver. C. Open the airway using a jaw thrust maneuver. D. Suction any visible blood or secretions from the mouth. Answer: C. Open the airway using a jaw thrust maneuver. This question tests your understanding of initial airway management, especially in trauma. The keyword facial trauma and collision are critical clues indicating potential cervical spine injury, which makes the head tilt, chin lift maneuver unsafe as it could worsen a spinal injury. The jaw thrust maneuver is the preferred method for opening the airway in trauma patients because it minimizes neck movement, establishing a patent airway while maintaining spinal precautions. Once the airway is open, you would then address any visible obstructions like blood with suction if necessary. A practical example is an unconscious driver after a car crash. Always use the jaw thrust first to protect their neck. Remember, trauma equals jaw thrust. Question 2. A 68-year-old male complains of sudden onset chest pain that started an hour ago. He describes the pain as a pressure in his chest, radiating to his left arm. He is prescribed nitroglycerin and has it with him. After assisting him with his first dose, his blood pressure drops from 140/90 mmHg to 98/60 mmHg. What is your immediate next action? A. Administer another dose of nitroglycerin. B. Have the patient sit upright to ease his breathing. C. Lay the patient supine and elevate his legs. D. Contact medical control for further orders. Answer: C. Lay the patient supine and elevate his legs. This scenario tests your knowledge of medication administration and managing side effects, specifically hypotension, low blood pressure, after nitroglycerin. The drop in blood pressure to 98/60 millimeter of mercury indicates a significant adverse reaction, as nitroglycerin can cause vasodilation and lower blood pressure. Laying the patient supine and elevating their legs helps return blood to the core, improving cerebral and cardiac perfusion. Administering more nitroglycerin or having him sit upright would worsen the hypotension, while contacting medical control is important but not the immediate life-saving intervention. If your patient's blood pressure drops after nitroglycerin, remember to lie them down and elevate their legs to help bring that pressure back up. Question 3. You are assessing an unresponsive 4-year-old child. Your primary assessment reveals a patent airway, but respirations are slow and shallow at 10 breaths per minute. The child's skin is pale and cool, and a brachial pulse is weak at 60 beats per minute. What is your most appropriate initial intervention? A. Administer blow-by oxygen at 6 liters per minute. B. Begin chest compressions. C. Provide positive pressure ventilations with a bag valve mask, BVM. D. Place the child in the recovery position. Answer: C. Provide positive pressure ventilations with a bag valve mask, BVM. This question focuses on pediatric respiratory compromise and the critical intervention of ventilation. The keywords slow and shallow respirations at 10 breaths per minute and weak pulse at 60 indicate inadequate breathing and impending respiratory arrest in a child. For pediatric patients, a pulse rate below 60 beats per minute with signs of poor perfusion, pale, cool skin, or inadequate breathing is an indication for positive pressure ventilation. While oxygen is important, ventilations are the immediate priority to support breathing. Starting chest compressions would be indicated if the heart rate drops further or is absent. When a child isn't breathing effectively and their heart rate is low, always assist their breathing with a BVM first. Question 4. While taking a sample history from a conscious 35-year-old male complaining of abdominal pain, he tells you he has no allergies, takes no medications, has no pertinent past medical history, and his last oral intake was breakfast 4 hours ago. What other specific question is most important to ask during your history taking to help determine the nature of his pain? A. Have you been under any stress lately? B. Can you describe the pain using the OPQRST mnemonic? C. Are you currently experiencing any nausea or vomiting? D. When was your last bowel movement? Answer. B. Can you describe the pain using the OPQRST mnemonic? This question tests your structured approach to medical patient assessment, specifically gathering details about a chief complaint like pain. While all other options are relevant, the most important next step to fully characterize the abdominal pain is to use the OPQRST mnemonic: onset, provocation/palliation, quality, radiation, severity, time. This systematic approach helps gather comprehensive details about the pain, which is crucial for diagnosis and treatment. The sample history provides general patient information, but OPQRST dives deeply into the specifics of their current complaint. When a patient complains of pain, remember OPQRST helps you get the full picture and understand their experience. Question 5. You are called to a construction site for a worker who has fallen approximately 20 feet from scaffolding. He is conscious but confused, complaining of severe back pain and weakness in his legs. Which of the following is the most appropriate initial action? A. Immobilize the patient's spine on a long backboard. B. Perform a rapid head-to-toe trauma assessment. C. Administer high-flow oxygen via a non-rebreather mask. D. Manually stabilize the patient's head and neck. Answer. D. Manually stabilize the patient's head and neck. This question assesses your understanding of immediate priorities in a trauma patient with a significant mechanism of injury and suspected spinal injury. The keywords fallen approximately 20 feet and severe back pain and weakness in his legs strongly suggest potential spinal trauma. Therefore, the absolute first action after ensuring scene safety is to manually stabilize the patient's head and neck to prevent further injury to the spinal cord. All other actions like assessment, oxygen administration, or full immobilization follow this crucial initial stabilization. Remember, in any suspected spinal injury, maintaining manual stabilization of the head and neck is your very first line of defense. Question 6. A 72-year-old female is experiencing sudden difficulty breathing, speaks in two-word sentences, and has audible wheezing. Her skin is pale and clammy, and her pulse oximetry reads 88% on room air. She has a history of congestive heart failure, CHF. What is the most appropriate initial intervention? A. Administer a bronchodilator via nebulizer. B. Place the patient in a supine position. C. Assist ventilations with a bag valve mask, BVM, and supplemental oxygen. D. Apply a non-rebreather mask at 15 liters per minute. Answer. D. Apply a non-rebreather mask at 15 liters per minute. This question addresses a common respiratory emergency, likely acute pulmonary edema due to CHF, and the initial management of hypoxia. The patient's presentation with sudden difficulty breathing, two-word sentences, wheezing, pale and clammy skin, and 88% pulse oximetry clearly indicates severe respiratory distress and hypoxia. While BVM might be needed if her condition worsens, for a spontaneously breathing patient in severe distress, high-flow oxygen via a non-rebreather mask is the most appropriate initial step to improve oxygenation. Placing her supine would worsen her breathing, and bronchodilators are for bronchospasm, not primarily for CHF-related pulmonary edema. For a patient struggling to breathe and hypoxemic, immediately get that non-rebreather mask on with high-flow oxygen. Question 7. You are assessing a 5-year-old child who ingested an unknown number of pills. The child is drowsy but responds to verbal stimuli. Their respirations are 12 breaths per minute and shallow, and the pulse is 58 beats per minute. What is the most appropriate initial management for this patient's breathing? A. Place the child in the recovery position. B. Administer supplemental oxygen via nasal cannula. C. Provide positive pressure ventilations with a bag valve mask, BVM. D. Monitor respirations closely and prepare for transport. Answer: C. Provide positive pressure ventilations with a bag valve mask, BVM. This question tests your critical thinking regarding pediatric airway and breathing management, especially in overdose. The keywords drowsy, respirations are 12 breaths per minute and shallow, and pulse is 58 beats per minute indicate inadequate breathing and bradycardia, slow heart rate, which are critical signs of respiratory compromise and impending failure in a child. For a child with an inadequate respiratory rate and a pulse below 60 to 80 bpm, positive pressure ventilation with a BVM is the most appropriate immediate intervention to support their breathing and oxygenation. Administering a nasal cannula or just monitoring would not be sufficient for these critical findings. When a child's breathing is too slow and shallow, and their heart rate is also low, jump straight to assisting their breaths with a BVM. Question 8. An adult patient is actively seizing on the floor. After ensuring their safety and protecting them from injury, what is your primary concern during the active seizure? A. Administering oral glucose to prevent hypoglycemia. B. Opening the airway and maintaining its patency. C. Obtaining a detailed medical history from family members. D. Restraining the patient to prevent self-injury. Answer: B. Opening the airway and maintaining its patency. This question focuses on immediate care for a patient experiencing a seizure. The primary concern during an active seizure is to protect the patient from injury and ensure a patent airway. While you cannot typically open the airway in a convulsing patient, it is crucial to position them to minimize aspiration risk and be prepared to manage their airway immediately after the seizure stops, as postictal patients often have compromised airways. Restraining the patient is generally contraindicated as it can cause injury. Administering oral glucose is only appropriate if hypoglycemia is confirmed and the patient is conscious and able to swallow, which is not the case during an active seizure. Your main goal during an active seizure is to keep the patient safe and protect their airway. Question 9. You are called to a restaurant for a 45-year-old male who suddenly collapsed while eating. He is unconscious, pulseless, and apneic. A bystander states he was choking. After initiating chest compressions, what is your next most important action? A. Perform a blind finger sweep to remove the obstruction. B. Check for a pulse and breathing again. C. Look for the foreign body and remove it if seen. D. Deliver 2 rescue breaths. Answer: C. Look for the foreign body and remove it if seen. This question assesses your knowledge of basic life support for an unconscious choking adult. Once a choking patient becomes unconscious and you've started chest compressions, the next critical step is to look inside the mouth for the foreign body after each set of compressions, or before attempting ventilations. If a foreign body is seen, you should attempt to remove it. Blind finger sweeps are discouraged because they can push the object further into the airway. Delivering rescue breaths without clearing the airway first may be ineffective. When an unconscious patient was choking, always look for the obstruction in their mouth after compressions, and only remove it if you can clearly see it. Question 10. You are performing a rapid trauma assessment on an unresponsive patient involved in a high-speed motor vehicle collision. You observe paradoxical motion of a segment of the chest wall. What does this finding indicate? A. A simple rib fracture. B. A ruptured diaphragm. C. A flail chest. D. A tension pneumothorax. Answer: C. A flail chest. This question tests your understanding of specific chest injuries in trauma. The keyword paradoxical motion is the definitive sign of a flail chest, which occurs when a segment of the rib cage breaks and detaches from the rest of the chest wall. During breathing, this segment moves in the opposite direction to the rest of the chest, indicating its instability. A simple rib fracture would not cause paradoxical motion, while a ruptured diaphragm or tension pneumothorax would present with different signs, such as diminished breath sounds or respiratory distress. If you see part of the chest moving in the opposite direction when your patient breathes, think flail chest and prepare to support their breathing. Question 11. An elderly patient with a history of diabetes is found unresponsive. Her blood glucose level is 45 milligrams per deciliter. She has a gag reflex. What is the most appropriate treatment for this patient? A. Administer oral glucose. B. Administer an epinephrine auto-injector. C. Request advanced life support, ALS, for 4-dextrose. D. Place the patient in the recovery position. Answer: C. Request advanced life support, ALS, for 4-dextrose. This question evaluates your knowledge of managing diabetic emergencies, specifically severe hypoglycemia in an unresponsive patient. The key here is the patient's unresponsiveness and low blood glucose, 45 milligrams per deciliter, despite having a gag reflex. While oral glucose is the treatment for conscious patients with hypoglycemia, an unresponsive patient is at high risk of aspiration if oral glucose is given. Therefore, the most appropriate action is to request ALS, as they can administer intravenous 4-dextrose, which directly raises blood glucose without aspiration risk. An epinephrine auto-injector is for anaphylaxis, and the recovery position doesn't treat the underlying hypoglycemia. For an unresponsive diabetic patient with low blood sugar, call for ALS to provide 4-dextrose, as oral glucose is too risky. Question 12. A 24-year-old female complains of severe abdominal pain and vaginal bleeding. She states she is 8 weeks pregnant and has not seen a doctor yet. Her pulse is 110 bpm, respirations 22 bpm, BP 90/60 mmHg, and skin is pale and cool. What is your primary concern? A. Providing emotional support for a potential miscarriage. B. Assessing for a rapid progression of labor. C. Treating for hypovolemic shock. D. Administering high-flow oxygen. Answer: C. Treating for hypovolemic shock. This question focuses on recognizing and managing a life-threatening obstetric emergency. The keywords severe abdominal pain, vaginal bleeding, 8 weeks pregnant, and signs of hypoperfusion, pulse 110, BP 90/60, pale and cool skin, are all indicators of potential hypovolemic shock, likely from an ectopic pregnancy or spontaneous abortion. While emotional support and oxygen are important, the immediate, life-threatening concern is the patient's circulatory instability. Rapid transport and aggressive treatment for shock are paramount. In any pregnant patient with bleeding and signs of shock, prioritize treating for hypovolemic shock and rapid transport. Question 13. Which of the following best describes the purpose of the secondary assessment in a trauma patient with a significant mechanism of injury? A. To identify and treat immediate life threats. B. To gather a detailed medical history using sample and OPQRST. C. To perform a systematic head-to-toe examination to identify all injuries. D. To determine the patient's level of consciousness using the AVPU scale. Answer: C. To perform a systematic head-to-toe examination to identify all injuries. This question assesses your understanding of the phases of patient assessment in trauma. The secondary assessment, particularly in a trauma patient with a significant mechanism of injury, is a thorough, systematic head-to-toe or focused physical examination. Its purpose is to uncover all injuries that may not have been immediately apparent during the primary assessment. Immediate life threats are identified and managed during the primary assessment, while the sample and OPQRST histories are part of the medical assessment, and AVPU is for level of consciousness in the primary assessment. After addressing immediate life threats in a trauma patient, the secondary assessment is where you meticulously check for every other injury from head to toe. Question 14. An unresponsive 50-year-old male is found in a prone position. There is no evidence of trauma. After ensuring scene safety and gloving, what is your first action regarding this patient? A. Immediately begin chest compressions. B. Check for a pulse and breathing. C. Carefully roll the patient into a supine position. D. Open the airway with a head tilt, chin lift. Answer: C. Carefully roll the patient into a supine position. This question addresses the initial approach to an unresponsive, non-trauma patient found in a prone position. Before you can effectively assess ABCs, airway, breathing, circulation, or perform CPR, the patient must be in a supine, on their back, position. Since there is no evidence of trauma, you can carefully roll the patient without strict spinal precautions. Once supine, you would then check for a pulse and breathing. Remember, if your unresponsive patient is on their stomach and there's no trauma, the first step is to gently roll them onto their back so you can properly assess and treat them. Question 15. A 60-year-old male with a history of COPD is in severe respiratory distress. He is alert and oriented, able to follow commands, and maintaining his own airway. His respiratory rate is 28 breaths per minute, shallow, and he is using accessory muscles. Pulse oximetry is 89% on room air. Which of the following interventions is most appropriate to improve his ventilation? A. Administer albuterol via nebulizer. B. Assist ventilations with a bag valve mask, BVM. C. Apply a non-rebreather mask at 15 liters per minute. D. Initiate continuous positive airway pressure, CPAP. Answer: D. Initiate continuous positive airway pressure, CPAP. This question focuses on advanced respiratory interventions within the EMT scope for a patient in severe respiratory distress, particularly with COPD. The patient is alert and oriented, maintaining his own airway, but has shallow respirations, accessory muscle use, and 89% pulse oximetry, indicating significant respiratory compromise and impending failure. CPAP is an excellent option for such patients, as it provides positive pressure to keep the alveoli open, improve oxygenation, and reduce the work of breathing, especially in conditions like COPD exacerbation. While albuterol treats bronchospasm and a non-rebreather provides oxygen, CPAP directly supports ventilation and is appropriate for this presentation. For a conscious patient with COPD who is really struggling to breathe, CPAP can often make a huge difference by helping to open up their airways. Question 16. What is the minimum frequency for reassessing a stable medical patient during transport? A. Every 2 minutes. B. Every 5 minutes. C. Every 10 minutes. D. Every 15 minutes. Answer: D. Every 15 minutes. This question tests your knowledge of ongoing patient assessment frequency. For a stable patient, whether medical or trauma, reassessment should occur at least every 15 minutes. This involves repeating the primary assessment, vital signs, chief complaint, and checking interventions. Unstable patients, however, require more frequent reassessment, typically every 5 minutes. Consistent reassessment ensures that any changes in the patient's condition are promptly identified and addressed. Remember, stable patients get checked every 15 minutes, Unstable patients need you to check in much more often, every 5 minutes. Question 17. You are managing a patient with a severe open chest wound. After applying an occlusive dressing, you notice the patient's breathing becomes increasingly difficult, and breath sounds are diminished on the injured side. Jugular venous distension, JVD, is also present. What is your immediate priority? A. Administer high-flow oxygen. B. Release one corner of the occlusive dressing. C. Prepare for rapid transport. D. Reapply the occlusive dressing more tightly. Answer: B. Release one corner of the occlusive dressing. This question addresses a critical complication of occlusive dressings applied to open chest wounds, the development of a tension pneumothorax. The signs of increasingly difficult breathing, diminished breath sounds on the injured side, and JVD, jugular venous distension, are classic indicators that air is trapping in the chest and creating pressure. The immediate intervention is to burp the occlusive dressing by lifting one corner to allow the trapped air to escape, relieving the tension. Administering oxygen is important but secondary to relieving the tension. If your patient with a chest seal suddenly gets worse with trouble breathing and neck vein distension, quickly lift a corner of that dressing to let the air out. Question 18. An alert and oriented 8-year-old child sustained a suspected isolated forearm fracture after falling off a bicycle. After immobilizing the injury, what should be regularly assessed distal to the injury? A. Pulse, motor, and sensory function. B. Blood pressure and respiratory rate. C. Level of consciousness and pupil reactivity. D. Pain level and verbal response only. Answer: A. Pulse, motor, and sensory function. This question focuses on the essential post-immobilization assessment for an extremity injury. After splinting any suspected fracture, it is crucial to continually assess the PMS, pulse, motor, and sensory function distal, below, to the injury. This ensures that the splint is not too tight, which could compromise circulation or nerve function, and that the injury itself is not causing further neurovascular damage. Blood pressure, respiratory rate, and level of consciousness are part of general patient assessment but not specific to monitoring an immobilized extremity. Always remember to check for pulse, movement, and sensation below any splint to make sure it's not causing new problems. Question 19. You are transporting a stable patient with a known history of chronic bronchitis. He is prescribed home oxygen at 2 liters per minute via nasal cannula. His current pulse oximetry is 92%. What is the most appropriate action regarding his oxygen therapy? A. Increase oxygen to 15 liters per minute via non-rebreather mask. B. Discontinue oxygen, as 92% is acceptable. C. Continue oxygen at 2 liters per minute via nasal cannula. D. Increase oxygen to achieve a pulse oximetry of 99 to 100%. Answer: C. Continue oxygen at 2 liters per minute via nasal cannula. This question addresses oxygen administration in patients with chronic obstructive pulmonary disease, COPD, or chronic bronchitis. The key concept is that for patients with chronic lung conditions, high levels of supplemental oxygen can sometimes suppress their respiratory drive. While all patients need oxygen, a pulse oximetry of 92% is generally an acceptable target range for a patient with chronic bronchitis. Therefore, continuing his prescribed oxygen at 2 liters per minute is appropriate unless his condition deteriorates or saturation drops significantly. Do not over-oxygenate patients with chronic lung disease. Aim for an acceptable saturation, often 88 to 92%. For patients with chronic lung conditions, it's usually best to stick to their prescribed oxygen level or a target saturation like 92%, rather than aiming for 100%, unless they show signs of severe distress. Question 20. A 28-year-old male is found unconscious with pinpoint pupils and slow, shallow respirations at 6 breaths per minute. You suspect an opioid overdose. After opening the airway and assisting ventilations with a BVM, what medication might an EMT be able to administer according to local protocols? A. Activated charcoal. B. Aspirin. C. Naloxone, Narcan. D. Oral glucose. Answer: C. Naloxone, Narcan. This question tests your knowledge of specific medication administration for a suspected opioid overdose. The classic signs of unconscious, pinpoint pupils, and slow, shallow respirations, 6 breaths per minute, strongly indicate an opioid overdose. Naloxone, Narcan, is a specific opioid antagonist that can rapidly reverse the effects of opioids. After ensuring airway and breathing, naloxone is the appropriate medication, often administered intranasally or intramuscularly by EMTs according to local protocols. Activated charcoal is for other ingestions, aspirin for cardiac chest pain, and oral glucose for hypoglycemia. For a patient with pinpoint pupils and very slow breathing, think opioid overdose and remember naloxone is the life-saving medication. Question 21. You are dispatched to a residence for a sick person. Upon arrival, you find a 48-year-old female who reports feeling generally unwell for several days. Her vital signs are stable, and she is alert and cooperative. What is the most appropriate transport decision? A. Immediate transport to the nearest trauma center. B. Rapid transport to a specialized cardiac center. C. Transport to the nearest appropriate medical facility via ambulance. D. Advise the patient to follow up with her primary care physician. Answer: C. Transport to the nearest appropriate medical facility via ambulance. This question assesses your ability to make appropriate transport decisions for a stable medical patient. The patient's presentation as a sick person who is alert and cooperative with stable vital signs and feeling unwell for several days suggests a non-emergent medical complaint. Transport to the nearest appropriate medical facility via ambulance allows for comprehensive evaluation, but does not indicate the need for immediate or specialized transport required for critical patients. Advising self-referral is usually not within the EMT's scope of practice when EMS has been activated. When your patient is stable but needs medical evaluation for a general illness, routine transport to the closest appropriate hospital is the way to go. Question 22. A 6-month-old infant is found unresponsive and apneic. A single rescuer is present. After confirming unresponsiveness and absence of breathing, what is the correct sequence of actions for this infant? A. Call 911, then begin CPR. B. Begin CPR immediately for 2 minutes, then call 911. C. Deliver 5 back blows and 5 chest thrusts, then call 911. D. Check for a pulse, then begin CPR. Answer: B. Begin CPR immediately for 2 minutes, then call 911. This question addresses the critical BLS sequence for an unresponsive, apneic infant when a single rescuer is present. For an infant or child, if you are alone and find them unresponsive and not breathing, you should phone first if you witnessed the collapse. However, if the collapse was unwitnessed, or you are the sole rescuer, you should provide 2 minutes of CPR before calling 911 or activating the emergency response system to ensure immediate intervention for a potentially reversible cause. Checking for a pulse is part of the initial assessment, but if apneic, CPR is typically initiated quickly. When you find an unresponsive, apneic infant as a single rescuer, always do 2 minutes of CPR first before you call for help. Question 23. You are preparing to administer an oral airway, OPA, to an unresponsive adult patient. Which of the following is a contraindication for inserting an OPA? A. The patient is snoring. B. The patient has a gag reflex. C. The patient has suspected spinal trauma. D. The patient has absent breath sounds. Answer: B. The patient has a gag reflex. This question tests your understanding of airway adjuncts, specifically the contraindications for an OPA. The primary contraindication for inserting an oropharyngeal airway, OPA, is the presence of a gag reflex. If a patient has a gag reflex, inserting an OPA can induce vomiting, increasing the risk of aspiration. An OPA is used to prevent the tongue from obstructing the airway, which can cause snoring sounds, so snoring would be an indication, not a contraindication. Suspected spinal trauma affects the choice of manual maneuver, jaw thrust versus head tilt chin lift, not necessarily the OPA itself if indicated for airway patency. Absent breath sounds indicate a need for airway intervention, not a contraindication. Never insert an oral airway if your patient has a gag reflex, because it could cause them to vomit. Question 24. While assessing a patient involved in an industrial accident, you observe significant external bleeding from a laceration on their forearm. What is the most effective initial method to control this bleeding? A. Apply a pressure dressing. B. Apply a tourniquet proximal to the injury. C. Elevate the injured extremity. D. Apply direct pressure with a sterile dressing. Answer: D. Apply direct pressure with a sterile dressing. This question assesses your knowledge of bleeding control techniques. The most effective initial method to control significant external bleeding from an extremity laceration is applying direct pressure with a sterile dressing. This directly compresses the bleeding vessels and allows for clot formation. If direct pressure is insufficient, a pressure dressing can be applied over the direct pressure. Elevation can be an adjunct but is rarely sufficient alone, and a tourniquet is reserved for life-threatening hemorrhage that is not controlled by direct pressure. When you see significant bleeding, your first and most effective step is always to apply direct pressure with a clean dressing. Question 25. An EMT is presenting a patient report to the emergency department staff. Which of the following pieces of information should generally be provided first? A. Detailed medical history and medications. B. Initial vital signs and trends. C. Chief complaint and general impression. D. Interventions performed and patient's response. Answer: C. Chief complaint and general impression. This question focuses on effective communication and patient handoff. When giving a patient report, it is crucial to start with the most pertinent information to provide the receiving staff with a quick overview and allow them to anticipate the patient's needs. The chief complaint, why EMS was called, and your general impression, what you see from the door, immediately convey the patient's primary problem and overall severity. The detailed history, vital signs, and interventions follow after this initial snapshot. When handing off your patient, always start with why you're there and what you immediately observe to give the receiving team a clear and quick understanding.